care. So after finishing pharmacy school with my PharmD, I did a PGY1 residency at a level one trauma hospital. It was 756 beds in Memphis, Tennessee. So the residency was a general pharmacy practice residency, and it included about 10 rotations, and that in addition to one administration rotation and one DUE or drug use evaluation rotation. In addition to the 10, and out of the 10, I think there were 3 or 4 that we could choose on our own. So I specialized in intensive care. After the residency, I was hired by a disproportionate share hospital, and we'll talk more about that later, where I was employed as the clinical pharmacy coordinator for 5 years. And the programs that are listed here are the programs that I managed as the clinical pharmacy coordinator. But just note the ones that have the asterisk beside them, because those are the ones that the hospital did not have that I innovated and implemented while there. So the Coumadin Clinic, the nutrition support, which is TPN management, renal hepatic aminoglycoside dosing, being the ICU specialist meant going on rounds, morning rounds with the ICU team, making interventions as far as assisting where it was appropriate to convert a patient from IV to PO medications, and when it was appropriate to make adjustments to the TPN and things of that nature. Formulary management is a big part of what I did in clinical, and that's with clinical coordinator, because again, a lot of times, and we'll see this even in the retail setting, the doctors want to use the new shiny thing, and that can bankrupt a hospital, especially one that has limited funds, very quickly. So formulary management was a big part of what I did. And joint commission, I'm sure all of us have had a time or two, if you're, especially if you're in a hospital, where joint commission comes in, and they're the accrediting body, so there are a lot of do's and don'ts and things you need to do to maintain accreditation. So joint commission audits were a big part of it as well. Now, the reason why I named all of these is because they all matriculated into what I ended up doing for AmCare. So the next slide we'll go to, and we'll finish what I was saying was that, so the second job that I had was with a community healthcare clinic, and also here in Nashville, Tennessee, where I was director of pharmacy for 8 years. There, I implemented their anticoagulation clinic because it became a point where you had to provide services or monitoring services for patients that were on anticoagulation medications. So that would be Coumadin, your Lovenox, even Eliquis was just beginning. The Eliquis and all those other medications were just beginning to be a part of therapy. So, of course, warfarin therapy was a big thing. Diabetes education, hypertension telepharmacy, retail pharmacy is a big part of it as well. But it's just not the same volume. Whereas I think some of my friends that are in retail can do anywhere from 600 to 900 scripts a day. This is very much a smaller volume, maybe 150 to 200 a day. But the other parts, the other clinical parts, were a big part of the day as well. 340B status, the VFC, which is Vaccines for Children program, a quality improvement committee, and joint commission audits and immunizations. So these are the different things that I managed while at the healthcare clinic. And again, the asterisk are those things that I brought there that they did not have at first. And the ones that I highlighted, the hypertension telepharmacy and 340B status, we're going to discuss those in detail. So first we'll start with our explanation of telehealth pharmacy. So the telehealth is defined by the health resources and service administration as the use of electronic information and telecommunication technologies to support long distance clinical health care. So again, what we're doing here is providing care to patients who have limited access to it. So think about your rural areas. So they're implementing an ambulatory care system, in ambulatory care settings, because again, we're trying to reach as many patients as possible in our rural areas, small areas, people that may not have access due to transportation, because sometimes there are very rare telehealth medicines in inner city. Not often though. Some of the sub clinics are pharmacist driven, and this is important because this is another way for pharmacists to be providers. So this relieves the patient load on physicians and nurse practitioners. And again, we're using our resources, keeping the costs down, using pharmacists to do the sub clinics, and again, not having to hire additional staff because the pharmacist is already employed, already there. So I'll talk a little bit about the experience that I had with telehealth medicine. So what I did, I had gone to a conference and I noticed that telehealth medicine was becoming something big on the horizon. So I wanted to see if this was something I could implement at the clinic to decrease our cost. So I wrote a grant letter to Walgreens Pharmacy asking if I could have 30 blood pressure cuffs. And what I wanted to do was have a telehealth or a telepharmacy hypertension program. And we picked 30 of the most at-risk hypertension patients. And what I did was when they came in for the regular visit, the doctor would suggest that they be in this program. They sign a release form and they come to me, and we really do an in-depth education about hypertension and the importance of measuring your blood pressure daily at home. So once they were educated on the importance of taking their blood pressure, I showed them how to use the machine and sent the machine home with them, as well as some forms so they could record their blood pressure readings. And I would call them once a week or once every twice a month, and we go over how they're feeling. If they started new medications, have they noticed anything different? Are they able to stay compliant and get those readings that they've had? And right then and there, I can make an intervention and decide whether or not the patient needs to come in for an earlier follow-up, because a lot of times follow-up may be 3 months later, or see you next year, or even 6 months later. So being able to to do something right away rather than waiting 3 months and come in and the doctor finds out there's 3 months of their blood pressure still out of control, still affecting their kidneys, their heart, and all the other things. Maybe the patient's having headaches. So the telemedicine program was a big hit. I did a presentation afterwards to the medical staff to let them know after about 3 months of the program being in existence. And although I no longer work at this particular healthcare clinic, they still call me to this day asking me about how to work certain parts of this program, since it was such an innovative thing to do. So next we'll go ahead and talk about the other highlighted item, which is 340B. Now this is important. So this is a big part of what the healthcare clinics are about, because 340B is a federal drug discount program, and it requires participating drug manufacturers to provide discounted prices on covered outpatient drugs. And they're providing these drugs to the eligible healthcare organizations or covered entities that serve the indigent and vulnerable population. So in a nutshell, if a drug is rebatable, if a drug manufacturer has a drug that is a rebatable drug, that drug is also eligible for this drug discount program. The drug is only available to healthcare organizations that are certified to be a 340B entity. They take those savings from purchasing these drugs and pass their savings on to the patient. So it permits these entities to stretch their federal resources in order to reach as many eligible patients and provide more comprehensive services. So with that being said, and again, it's timing out. Okay. The different pieces that are involved in 340B include HRSA. We talked about them earlier, the drug manufacturers, the covered entities, and these are the AmCare facilities, the patient and 340B Prime Vendor Program. The Prime Vendor Program, I won't go into detail about that because that's not the important part. That's just the resource that the facilities would use to stay up to date on pricing, on the when things are in stock and not out of stock. So it's basically a resource they would use when purchasing their medications or making changes to their formulary. So this is just a picture of what a healthcare clinic would normally look like, but they service patients that are at or below the poverty level. And oftentimes they have little to no money to do a lot of programs, but that's where the pharmacists and the different providers come in to assist because we want to be able to still provide quality care despite the fact that the resources are limited. So now that I've talked about my journey, I want to talk about possibly your journey. How can you get into ambulatory care? Leading up to this presentation, I've had the pleasure of talking to a number of pharmacists that are interested in getting into this arena that want to do something more fulfilling or more challenging, or they're just a change of pace from the many things that are asked of you in the retail setting. So how can you get into it? So I made 3 different columns and I divided them by free things you can do if you have the money at the right away, or if you have time and money. So first we'll start with the free column. The 340B University, that is a free, and you get a certificate at the end, but you can do the program, and it takes about, I would say it would take half a day. If you have a free Saturday, you could do it on a Saturday and get it done. But it teaches you the operations of 340B. And that's important because 340B, if it's used properly, can save a healthcare clinic hundreds of thousands of dollars each year. And that can go towards providing other services that the clinic is looking forward to. It can be used to improve technology. It can be used to improve the flow of business, because a lot of times you'll have a number of patients waiting to be seen, and sometimes if you can provide a certain I'll say software that can help speed up certain things where you don't have to do so many things manual, then it can help speed up how many patients you can see. So being able to save the money so that you can afford that is one. Getting your own NPI. That's quick. It should take about 15-20 minutes. I think every pharmacist, the first thing you should do after you get your license from taking your boards is get your NPI. Your NPI allows you to become your own provider, and especially in states that recognize that, it'd be helpful if you have your own, because you're then able to bill. Also, concentrate your CEs, because we always have to get CEs anyway. So concentrate your CEs on primary care. And I listed several different diseases or things that you could concentrate on: smoking cessation, vaccination, cold and flu, allergy, all these things to stay up to date, because the more you know, the more you're actually able to innovate and implement into your healthcare sites, then the more money they're saved. The second column is money and monetary investment. So the first one is a certified diabetes educator, and you'll see it's highlighted. So we're going to talk more about that later. But those 3 websites right there will allow you to go on, click, read, get more information about certification, and as well apply for it. The second thing is the immunization certification, and it just so happens that APHA has a certification course coming up on July 11th. So that's one thing that you could do that would help, because the site that I worked for, I can tell the name, Matthew Walker Comprehensive Health Center here in Nashville, Tennessee. They had 3 sites. And of those 3 sites, Nashville was the biggest and the first one, but they also had 2 satellite sites, one in Smyrna, Tennessee, and another one in Clarksville, Tennessee. And so sometimes they would not have sufficient staff to do the immunizations. So sometimes me as the pharmacist, I would help them with their flu clinics. Attend the 340B conference, and that does cost a a lot, because I think registration is usually about $600, and then you have hotel, and some of the meals are provided with the conference, but not all. But you would learn more about operations, and that one actually will probably be best done if you're already employed. Um, MTM certification is really big. Um, that is a program that I think more healthcare clinics want and need. And it's very important to get those, because when they're done and done well, they save a ton of money, a ton of money. So MTM certification and this implementation, I think, are really, really paramount. And other certifications at your local College of Pharmacy. I know here, Belmont University College of Pharmacy offers certifications, maybe 2 to 3 certifications a year. And most recently, I received my certification in pharmacogenomics, which marries pharmacy and genetics. And then previous years before, I got my MTM certification from Belmont as well. And this year, I think they're doing one that marries pharmacy with information technology. And then time and investment, residencies, PGY1 and PGY2, which are PGY2 are usually the specialized ones. And that is time and money, because I know most of us here have pharmacy bills, and you used to make in 6 figures. And residencies at this point, they may make 50,000 a year, maybe a little bit more, but having your salary cut in half and it being so for a whole year can be a bit much. But if you can, residencies can improve what you're able to apply for, especially since you're interested in changing totally into ambulatory care. Mid-year, which is where a lot of the residency representatives will be, this year is in December 2019. And the second highlighted part is the ambulatory care board certification. We'll talk about that and certified diabetes educator. So first up, we'll talk about the certification for diabetes educator. And what they do is they educate individuals and the community on the management of diabetes, and they counsel on good nutrition, healthy eating habits. They educate about necessary lifestyle changes and things that involve living with diabetes, discussing the importance of the medications and physical activities and glucose testing, which is big. They also collect patient data and proactively manage the patient's condition. So before we move on and talk about the requirements, what I want to say is at Matthew Walker, they received a grant from AstraZeneca, and the program that they received the grant for was called Dial Down Diabetes, so it's triple D. And what I did with that grant and that program is that we held monthly luncheons, and we would educate patients about the importance of diabetes management and changing their habits. And one time I remember talking to the patients, and we had a good attendance that day. It was about 20 patients that day. And I remember trying to educate patients about what carbohydrates were, the difference when I say carbohydrates, starch, sugar, all those different things, all those things mean the same thing when they're broken down in the body. I had one patient raise her hand because I talked about different foods that were qualified as starch, and she said she got upset because she didn't realize that grits were a part of carbohydrates. And she said, I'm from Atlanta. We put grits with everything. She was so shocked about that. So you'd be surprised what people do and don't know. So don't overlook the importance of, even before your certification, about really educating your patients about diabetes. So that always tickled me, because when I explain it, when you say sugar, because they're in their mind, they're thinking actual sugar, things that taste sweet. They're not thinking about the grits, the potatoes, the breads. So how can you become certified? So let's talk about those requirements. So you must be a licensed pharmacist practicing for 2 years before you apply. So it's not going to be for those new graduates. You must have obtained a minimum of 1,000 hours in diabetes education within the 4 years of applying, and 40% of those hours need to have been accrued within the year preceding. So let me break it down. within the previous 4 years, you need 1,000 hours, but 40 of those hours you need to have gotten within the year, and they all need to pertain to diabetes education. A minimum of 15 hours that are applicable to diabetes must have been earned within 2 years prior of applying for the exam. And the exam cost about $350. I just checked that recently, so yes, that's still the cost of it. And for more information, there's the website there, those two websites that you can check out. And I'm not sure if you're able, but I'll leave that slide right there for just a second if anybody wants to get those websites right there. Okay. So, how can you be eligible to sit for the board certified AmCare exam? That was the other part that was highlighted in the three different things that you could do in the column. So, there's three different ways that you can be eligible to sit for the board exam. The first one is if you have 4 years of practice experience. And this is practice experience that you earned after you have been a pharmacist, after you've gotten licensed as a pharmacist. And it includes 50% or more of that time spent practicing in the domains described in the AmCare outline. And I listed the website there because it's quite detailed. I don't want to, in essence of time, I don't want to take up a lot of time because it's very detailed, but that's the website where it explains what 50% of that time is. A second way is if you've completed either a PGY1 or a PGY2 residency, any residency in any type of focus, but you must also have 1 year additional practice experience. So again, you can do your residency, but after your residency, you also need to have worked at least a year. Your residency does not count as that 1 year of practice experience. So it's an additional year of practicing as a pharmacist. And again, that includes 50% or more of that time spent practicing in the domains described in the AmCare pharmacy outline. Third and final is that if you've completed a specialty residency, a PGY2, specialty residency in AmCare, that makes you instantly eligible to sit for the exam. So those are the three ways. And again, you can go to www.bpsweb.org, and that gives you a lot more detail as far as what you can do, and define what column you fit in to see which way you can become eligible. So now we talked about the different ways that I came into it, things that you can do. How can if you feel like, okay, I have all those things, I have this certification, I have that certification, I know about that, how do I find the actual jobs? You can also look for jobs in community pharmacy. A lot of times you're looking specifically for AmCare, but also look for community pharmacy positions. And that'll be a fusion of AmCare and the traditional pharmacy setting. But again, it's the part of just getting started. So positions such as clinical staff in the hospital setting are great foot in door positions because again, I started as a clinical pharmacist in the hospital. That gave me the stepping stone I needed to get into ambulatory care. And your local pharmacy schools, they're always looking for AmCare pharmacists. And the reason being is that because that's a double whammy for the pharmacy school, because you'll also be a part of their faculty and staff, and then your practice will also be a practice site for their pharmacy students. So don't leave out academia as far as a way for you to get in AmCare. And if you're able to and consider a part-time positions, that's also a great entryway because again, you just want to get your foot in the door. You want to get the experience. You want to get it on your resume. And so my last part that I want to really talk about moving into is really encouraging that to bring your innovative game, because these facilities have little to no money. Resources are scarce. They're nonprofit. So if you're able to accomplish a lot with a little, then you'll succeed. So that was the importance of me in the beginning, talking about the different programs I implemented, because they were things where I had the knowledge base. They were already paying me as a staff person. So it just took a little more work, but it wasn't an additional cost to the facilities. The grant writing that I did to get the blood pressure cuffs, that was a no cost, but we were able to improve the way we treated highly at risk patients that had hypertension. I was already there as a director of pharmacy. I already knew the way to educate. That's a part of our jobs every day. So it was a program that cost the clinic nothing, but the impact was great. You have to be compassionate. And the reason why I say that is because there is more than, you have to change your way of thinking. I know when we're in the Walgreens and CVS's or any of the retail settings, if a patient says they don't have the money, then we're basically stuck with, okay, well, it'll be here for 7 days or however many days, and then we'll have to put it back. Well, that's total opposite. In the AM care settings, your job is to make sure the patient goes home with the medicine. So we find ways. We do patient assistance programs. I had my technicians assisting the patients with filling out the applications, because some are elderly, some are unable to read because maybe they don't have proper education, or they're from a different country and don't fully know our language. So be compassionate and really go the extra mile for your patient is a big part of AM care, because again, you don't have the resources, but the patient still need care. Don't get stuck at the stepping stone position. Look to advance yourself every 3 to 5 years. I say this because I spoke recently with a pharmacist that had been out practicing in a retail setting for 5 years and wanted to get into ambulatory care. So they saw they kept being unable to apply for jobs because they were looking at the qualifications saying, I don't meet this qualification, I don't meet that qualification. But the company they worked for had a position that was more or less an outreach position. But they were so burnt out at their current position, they didn't want to try to apply for this outreach position. And I said, you're looking at it the wrong way. You don't have to stay there forever. This outreach position will diversify your resume. And then 2 years later, 3 years later, you'll have that experience to move to the next step. So sometimes it's a stepping stone process, not so much as a leap. Get the certifications and use them. If you get your MTM certification, if you do the 340B University, definitely highlight that on your resume, on your CVs, and use them. And you don't have to wait before you have those jobs to start implementing some of the cost-saving things that you're already doing, especially when you're in those hospital settings. It's a little hard to do in the retail settings, but definitely in those hospital settings. Sell yourself on your resume and in the interview on what you have done to set yourself apart since graduating school. Now, this part is really important. There was a high population of Hispanic patients at my clinic. And so learning to speak Spanish was big. I knew how to speak Spanish, but I knew conversation Spanish. Medical terms and medical verbiage is very different in foreign language. So I found myself educating myself again to be able to speak fluently with my patients. Now, albeit I learned to ask yes and no questions, but I was able to communicate with my patients, and I learned that I could understand way more. I could hear and understand way more than I could say. So I learned really, really quickly how to communicate with them so that they could just answer me yes or no. And then find out what you like and concentrate there. You're not going to be able to be a plethora of knowledge on every single thing that the clinic comes up against. But what you can be is a specialist in a certain area. We all know the gist of what we know when we're working in retail settings about the different drugs and the different diagnosis that goes with them, and when there's an out of scope certain thing. But in the AM care setting, if you have the anticoagulation clinic or if you're a diabetes educator, then those things are helpful because they'll look to you to be a specialist in those areas. Now, I have to admit, all those things that I did, and there was a lot of them that I did for the health club clinic, it was because I was the only pharmacist. So I needed to be more than that. But most of the times that's not the case. Most of the time they have a staff of pharmacists. So you're able to be able to specialize in a couple of things. So that's important. So lastly, just apply, don't sell yourself short. I always say, don't tell yourself no. Let them tell you no. I am okay with getting a letter saying we decided to go in a different direction. Thank you for your application. Rather than sit there and look at the job on LinkedIn or on uh, what is the other one, Indeed or whatever, Monster. Rather than keep looking at them, just thinking I would love to have that position. Well, you'll never know. So just apply for it. Because again, I went into the job at Matthew Walker. I applied to the staff pharmacist position. I applied in January. In November, I was the director of pharmacy. So you never know. So go ahead and apply. Don't tell yourself no. Let them tell you no. Be okay with being rejected because you only need one yes. Get your resume professionally done. That's some of the resumes that I come across when I was a director. I could tell that the person had done them themselves. Some of the flow and the format was off. There's a certain way where you can that professional resume writers do, and they can really get the attention that you need from the future employer. Also use LinkedIn. And lastly, network, network, network. I think a lot of times we keep a lot of information to ourselves because we think, oh, I want that job. I'm not going to tell so and so about that job. Or I'm not going to tell another person that there's an opening here. There's enough room for all of us. Just remember that there is enough room for all of us. So network, let people know what you're looking for and what you want, and be members of your different organizations and go for it. Really, if I could encourage you, really go for it. So again, just apply. So right now I would like to administer the second part, the post test part, and after that I'll let Sidoni have it back. But right now we're gonna go ahead and do those 4 questions again, and we'll see how we did.
Nikki, okay, good. Sorry about that.
No problem. Okay, so if y'all take some time to go ahead and answer, I'll give you another minute. And do I need to scroll down so they can see them?
Everyone should be able to scroll on their individual screens.
Okay. It'll take about 30 more seconds and we'll finish up here. Okay. Looks like some are still answering. Okay. So let's see here. So with the first one, the select the true statement. The true statement is, oh man, it looks like most of y'all answered the first question a little different. Let's see. Sidoni, one quick question: how do I? Does it? Do I tell the answer, or is it showing the answer?
You tell the audience the answer.
Okay.
The correct answer.
Okay. So with the first one, select the true statement. The answer is actually the second. They are designed to provide care in areas with limited access. Most of you all chose the third one, and telehealth medicine is defined as and hold on, let me go back to my specific statement on that slide. It is defined as the the use of electronic information and telecommunication technologies to support. It's not timely. Hold on. To support places that have limited access to healthcare. Not timely is a limited access to healthcare. So the answer is B. They are designed to provide care in areas with limited access. True or false, 340B is a state-funded drug discount program. That answer is false. The reason why it's false because it is not a state-funded drug discount program. It is a federal funded drug discount program. So each state does not do their own program. It is a federally funded program that is designed to permit covered entities to stretch federal resources and excuse that typo, stretch federal resources in order to reach as many eligible patients and provide more comprehensive services. Number 3, which statements are true regarding requirements for becoming a certified diabetes educator? That you must be a licensed pharmacist practicing for a minimum of 2 years prior to application, obtain 15 CE hours applicable to diabetes within 2 years of applying for the exam. C, of the 1,000 hours of diabetic education experience required, 40% of those hours must have been accrued in the most recent year before applying. All of those are correct, all of the above. And last, which statement is true regarding a way to become eligible to sit for the BCAC exam? Completion of a PGY 1 or 2 residency only. The reason why that one is not the correct answer is because if you do either or residency in any type of specialty, you also need to have 1 year of practice. So it's not just only the residency, it's the residency plus 1 year of practice. Completion of a specialty PGY2 residency in AM care only, that's the correct answer. So if you've done a specialty 2nd year residency in AM care only, that is the only thing you would need if you did that to be able to be eligible to sit for the exam. And then 2 years of practice, including 50% or more of that time in AM care, is not 2 years, it's 4 years of practice. So if you have not done a residency, then you have 4 years. A residency alone takes off 3 years, but an AmCare specialty residency requires no further years. So, with that being said, that completes my presentation. I would take it back to part for Sidoni to complete, and thank you.
Thank you so much, Dr. Bennett Carter. This was just amazing. We do have a couple of questions, and if anyone has any questions while we start with these, please go ahead and type those into the chat box. We are also on Facebook Live, so we will be looking there as well for any questions submitted. So this question is basically a two-part question, but I think the very first part of it has been answered by another audience member. Where do pharmacists go to apply for an NPI number? And I think someone put the link in the chat. So if anyone is
Yes,
interested in that information, please look in the chat box for the link. And then the second part of this, Dr. Bennett Carter, is what type of information is needed when a pharmacist is applying? Is there anything special, or is it just basic demographic and professional information that's needed?
that's exactly it. It's basic demographics, and then they're gonna want to know your employer. So if you change jobs, you'll need to go on the website. When I moved from the healthcare clinic into managed care, I had to go onto the website and update my information, because if you're using this in a setting where you're billing, then you'll definitely need to have the correct information. So just making sure it's update.
Okay. Now, does the pharmacist have to be employed to get an NPI number?
Do not.
Okay, cool. All right, our next question is states like Maryland have regulations for pharmacists to prescribe oral contraceptives. What are your thoughts about that in regards to AmCare?
Okay, that's an excellent question. And it's a big part of what you will be able to do if in an AM care setting, and you're able to provide uh, um, that service, because and I'll use my setting, my former setting, as an example. I mentioned that our site had my particular employer had 3 sites. Clarksville, Tennessee, and Smyrna, Tennessee, are equidistant from Nashville. They're both about 45 minutes away from Nashville. They're smaller, more rural areas, so that's where our satellite sites were. And both of those sites had a huge Hispanic population. And at one point, our Hispanic population was driving our OBGYN department. So being able to provide that service, and I do not want to dumb down our profession, but if we're already there, it doesn't cost the clinic any more money to have to bring in, say, a PA or nurse practitioner. I'm always for advancing what our scope of practice, because again, we took all the pharmacology, the medicinal chemistry classes, the therapeutic classes, so we do know. So I think yes, that's a great service to be able to bring into the clinics, especially if there's no OBGYN on site, because a lot of times family care will also see patients and be able to conduct those types of visits. So if you're there available to prescribe and assist with that, it'd be great.
Okay, thank you. So this is diving into the BCACP exam. So and this is just a random case example. If we have a pharmacist who's been out of school for about 5 years and they're working at Walgreens and they're ready to sort of make that transition into the AmCare setting, and they want to sit for the exam, what would be your recommendations on how to obtain that 50% requirement? That is in place, or that is that is required before being eligible to sit for the exam? How would you recommend to go about obtaining those requirements?
Now, I know Walgreens has some outreach programs or outreach pharmacist positions where pharmacists are doing MTM. If you're able to get into that particular position within the company, and do those and be the pharmacist that conducts those MTMs, the hours that you spend doing it can be used towards your 1,000 hours. Another thing that I always talk about is when we go out and we volunteer to work in these health clinics or the different things, local. I'm saying churches. I know everybody doesn't go to a church per se, but churches or local organizations that have these health clinics, if you're there volunteering to do blood pressure screenings or do point of service glucose testing, those sort of things, document those. Just get the person that organized it, that's over it, to sign off to say you were there and you did do those services. But you got to think out of the box, and not every single hour is an hour that you were uh, physically paid for in dollars, but maybe you volunteered your time. Volunteer time does count. So I would say think outside the box and get out in the community and participate, because that's what it's going to be about ultimately if you're able to gain employment.
So, what about immunizations, counselings, interventions made in certain therapeutic areas, say for like diabetes or hypertension or heart failure, anticoagulation? Can those be can the hours spent doing those services count?
The hours can count, but the thing is to get another person to sign off
Okay.
on those hours. So your manager, your district manager, will have to sign off as a way of saying, yes, this was performed. Yes, I do certify this as being this type of hours. So
Okay.
it's really going to be up to the individual pharmacist to document, but then just get someone to sign off on it.
Okay. And this leads into the next question. I think you probably already answered this, but I'll just restate it for the sake of completion. Is working as a retail pharmacist, or does working as a retail pharmacist count towards the 1,000 hours needed to apply for the CDE? So this is different, I guess, not the BCACP. This is
Yes.
about the CDE.
No, it does not. It accounts for the fact that you're a licensed pharmacist, but you're gonna have to, again, the documentation to show, because they're concerned with how you spent your time, not that you just spent time being a pharmacist, but how did you spend your time being a pharmacist. So they were talking about if you can document the part where you've done education. So I know a lot of times when we're speaking to diabetic patients in a retail setting, it's quick. It's a couple of minutes here or there. It's not like you're spending a whole lot of time. So if you can kind of, I would say, approximate, like in the beginning, you may be detailed 10 minutes here, 2 minutes here, but over time, if you can say that on average every month you're spending 30 hours a month, and I'm greatly approximating because it could be higher than that, it could be lower than that, depending on your setting, but be able to document that you did those hours is big.
Okay. And
Yeah,
I just went back to the slide
yeah.
about the CDE for anyone who wants more specific information on that. Now, are there courses that you can take, like paid courses that will give you the education you need to sit for this exam? Or is it only through the CE, the 15 hours of CE?
I'm I'm thinking of the website. I want to say that it is, I want to say freece.com. Every now and then if you're a part of their mail list, they'll send it to you. But they also do MTM certification as well as getting diabetes education certification. But those two websites were those two that are listed at the very bottom were the two that can direct you into how to get those hours. But yes, um, it's costly. I have a friend that recently did it. It is costly, but yes, you can. Free CE is the first one that comes to mind. FreeCE.com.
Okay. Alrighty. I think this is the last question. No, there's probably one more. As a clinical staff pharmacist in a pediatric hospital, how easy or how difficult is it to make the transition to AmCare?
I don't think that is difficult at all because AmCare has just about every single one of them I know of has a pediatric uh, part, and so my boss at the healthcare clinic that I worked, although she was the medical director, she was also the pediatrician. So her specialty and her nurse practitioners and her staff would definitely focus there. But in order to, you're gonna work with other pharmacists. So that's the thing. My position was unique in that I was the only pharmacist at my site. However, you'll work with other pharmacists, and then being in AmCare, you're going to pick up and learn more. So if you're in a clinical position right now and you just so happen to be in a specialty position, I still would start concentrating my CEs to kind of gain information to switch over because I mean, as we know, dosing and different things are different in the adult population. Geriatric is totally different than our regular adult population. So I would start learning, but I don't think it would, by far, no, it would not prohibit you from being in AmCare. No, it wouldn't.
All right. I think that was our last question. Thank you again, Dr. Bennett Carter. This was amazing. I'm just going to go ahead and talk about some last minute items. If there are any more questions, please feel free to type those in. A gentle reminder, we do have our second annual convention coming up in Las Vegas, and we will have many more of these types of robust scientific presentations. So please, if you're able to, it'll be a 2-day event. Um, and there's our flyer with our keynote speakers. We will be talking about the profession of pharmacy, current contemporary issues. Here is a screenshot of our program, communication workshops, financial workshops, scientific sessions as well, and a professional development. So if you're able to join us, please register. You can find more information on our website, which is www.camphausa-usa.org. And if you want to register for upcoming webinars, our next one will be in August, and it will be around immunizations. So just in time for the mad rush that we get in the fall with flu season. Please follow us on Facebook and Twitter. And for any registered members of our organization, Dr. Bennett Carter has been so gracious to allow us to share her information with you. If you have any ongoing questions or you want some one-on-one communications with her to answer any questions, we will be loading the slides from this presentation along with the recording into the member portal. So thank you again. We appreciate you taking your Sunday evening. Dr. Bennett Carter, you've been amazing to work with. I just wanted to let you know that we really appreciate your time and doing this for us, and just fostering our goal of being the best that we can be at our jobs as pharmacists. Thank you again, and have a good night, everyone.